Swayam Prabha. Digital India. Educated India.
All right, good afternoon. Welcome back. Let's continue. So when we left, we talked about expanded applications of artificial intelligence and machine learning in healthcare supply chain management. We talked about demand forecasting as one of the areas. Let's move on to the next one. Did we finish inventory? I think we finished inventory management also. And yeah, logistics optimization, we finished that. One of the areas that is pretty interesting is the predictive maintenance area of any particular business. Because, when a machine or when a vehicle or anything breaks down, then breakdown maintenance is much more expensive, right? So compared to if you can prevent it from happening. And so the predictive maintenance is a place where the AI models work really well, looking at the consumption patterns and past breakdowns and type of intervention that happened at the past breakdown, and so on and so forth. Thank you. The other area is clinical supply chain optimization. So the problem here is, preparing surgical kits tailored to each procedure, which is a huge thing because it's a very value-added thing. So that again, the triple effect, if the surgical kits are not properly prepared, they may delay surgery. And so that's an important part of it. And, any kind of expired or unused items should not be there. And so these kind of issues can be handled by the predictive models estimating likely consumables of scheduled surgery. You can look at the scheduled surgeries over a period of time and analyze it to kind of predict in the future what kind of consumption patterns are happening based on the surgeries in the past, and optimizing usage patterns based on physician-specific behavior. So in the past, when the surgeons interacted with the patients, what kind of surgical materials were used and optimizing on that. So examples include Mayo Clinic AI models suggest surgical kit contents based on historic utilization data, reducing waste. Most of these kinds are ordering more or ordering things that are not used. So that if you can minimize that, and then forecast anesthesia drug needs. So want to turn it again to you all to see if there is any people are here in clinical and hospital administration and things of that. Anything that rings your bell for you in terms of clinical supply chain optimization? Nobody? The nursing people, do you see anything in terms of that just the use of materials in the area that you were providing services to patients? How did you account for that? Were there issues? Could it have been better? Speculate. Okay, so anything comes to your mind, let me know. Same thing. I mean, the drugs that are used in anesthesia type of procedures, again, those have life kind of cycle, time-consuming, time-sensitive type of things. If you order more, then you have an issue of wastage. If you order less, obviously a shortage. So looking at scheduled surgeries over a period of time for a particular surgical unit. The surgeries need anesthesia, right? So how do you predict the material consumption of anesthesia that to be used again, anesthesiologists are going to have some uncertainty around that. So it's not like they're going to say, I'm going to use exactly, pick a number, 4 bottles of anesthesia for this patient, because patient's behavior under surgery is itself a little bit of variable. And so you go by surgical type and the past consumption as a data point. Then history of the patient is another data point, right? Because a patient going through the surgery, they have particular history and their interaction with that surgical procedure. And did that need more or less anesthesia? Again, no, it is the anesthesia that is used to put you under sleep so that the surgery can be. Both sides. Yeah. The drug that is used to induce this anesthesia type of thing. That's what I'm understanding. As how do you forecast? Okay. Another area. So we looked at many areas so far: forecasting in general, supply chain materials, inventory management. Now we are talking about patient flow and bed management as an area to look at. ICU bed shortages is a problem to think about because you have limited resources there in any ICU. So predicting admissions, discharges, transfers, using that information or predicting those things could be a problem always. How many admissions are going to happen is not completely under your control, But there may be some average during a week kind of a thing. Discharges, an uncertain kind of a variable to some extent. Transfers is coming from somewhere else to that place to get procedures. So that's, or scheduling diagnostic tests and surgeries to minimize bottlenecks. So, if you have to have a diagnostics test done before you do a surgery, those kind of things. Again, all these are ripple effect examples. So, queuing models combined with, machine learning. So queuing theory is an area in mathematics and OR, right? So it's nothing new. It's an established way of looking at when things come into a resource and queues up, what's the best way to handle that? So that you can understand the average statistics about the system, how long it will take how long will the patient stay in the system? How many patients will be in the queue? All those kind of things can be calculated. But when conditions change, when you have additional uncertainty, things like machine learning comes in a little bit more handy to introduce these additional constraints along with queuing models to give you better results. So that's where most of more complicated analysis is heading, is a combination of what we know from the past as techniques that have worked, and how do you augment them with these machine learning type of models. Professor, any thoughts on queuing models in general? And that's why I wanted to bring that. So there's the third one that they talk about, the natural language processing applied to clinical notes to estimate probable length of stay. That's an interesting one. So that's, you get unstructured data now. How do you use that and process that to inform you that a patient is going to stay long? Maybe there was some hint that was given of something that's not directly related to a queuing model input, right? So the queuing model needs input on how long, the time-based variables. Whereas qualitative variables like a patient's condition or something else that the doctor feels like want to observe for a few more hours. Comment like that. Does it apply across patients of similar types? Those type of thing is where machine learning comes in handy to cluster those things and analyze. So examples are given on Johns Hopkins Capacity Command Center, real-time AI dashboard, something that Professor Sundar talked about. Cleveland Clinic machine learning models to optimize scheduling of imaging equipment, reducing patient wait time. So if you looked at one of the slides that I showed a couple of days ago on what are some of the research topics post-COVID, patient wait time has become a number one topic post-COVID. Because suddenly, we all found this new sense of frustration when we go interact with the system after COVID. We might have interacted with that system before and we would have waited, but suddenly we are impatient. So the perception on a same system interaction pre-COVID to post-COVID, a lot of studies show behavioral changes. So children sitting in a classroom after COVID was a big issue for them to relearn things. So from the Indian context, I've come across two things. One is the potential high impact application in government tertiary care hospitals where overcrowding is chronic. So how do you address overcrowding is an issue. And then there's a Bangalore's Commander Center pilot used real-time ML forecasting for ICU beds during COVID. So those are two examples. I think the second one, IISc Bangalore had something to do with the input of creating that. Comments, questions on this is something that you all understand. This is patient flow through a system and bed management. This is where the maximum complaints happen in healthcare, right? So people waiting time increases. This, say it again. If the hospital wanted to, I lost you there.
So let's imagine there are people are coming and going to the hospital. That hospital need to put more human resource and technology to analyze all these things, like by using AML models to analyze people are coming and going, right? That is more cost to the hospital, right? Why would hospital need to adapt this kind of challenge, new things?
Okay, so it's a good question. What are the thoughts? Let's put it back to the class. Why does a hospital have to discharge a patient quickly?
Yeah, so my question is like, see, again, that hospital need to put more cost on the human resource and technology part, right? That is affected to the patient. If you go to general government hospital, there is no technology, there is no anything human resource extra for this kind of things. So the cost is very low for government as well. But in corporate hospital like Apollo, Narayana, whatever, so the cost is very high because of this human resource and technology part. So that cost will be again affected to the patient itself. That is more cost. Why hospital need to adapt these new challenges?
Yeah, after you, then go to.
So when it comes to patient overflow, people don't mind waiting sometimes in Apollo hospitals, but then again, they are distressed and it causes distress to that people. So in that context, when you think about it, it helps.
Okay.
It helps for the patient to get access to the doctor fast.
I understand that point, but what?
So that's why hospitals need to invest in ML kind of.
MLA models.
Yes.
That's I understand. But again, if I got a fever, if I go to government hospital, my cost is 0. Again, if I go to Apollo hospital, my cost would be like 3 to 4,000 for just normal checkup.
Why are you going to Apollo?
Like,
Don't have, I mean, why?
That is based on quality.
Where are you going? Don't go.
no sir. Anyway, people are going for Apollo or Narayana, whatever, corporate hospitals.
If next one will talk to the input.
Again, it's a additional cost to the hospitals that is affected to the patients, right?
Cost will be more.
Good.
If you look at from investment point of view, and in a long-term strategic decision or investment, it would help. If some if you have these datas, and if it is presented in the accessible to the general public, they can plan the visit to the hospital. If you are going and coming back, it will cause lots of fatigue on public level, also infrastructure, also cost, also many things will be there. Like if somebody is fit and fine, they can go run and get back. But if you are carrying the patient together with you, I had a practical example. We have Sanjay Gandhi Cancer Hospital in Delhi. So if somebody is traveling from Bihar and they don't get seat, they don't have a hospital to stay. They don't have a home either. They will be traveling here and there. But if these data are available due to any means, they could plan. Because anyway, we have this scarcity. This trade-off is already there. We are in need. We have huge demand, but we still have very little and scarce resources, hospital. So these data would actually help.
So the same point I wanted to add on. So when we digitalize, ultimately human resource will come down.
Yeah.
That is the idea. Like MRD, in speaking to MRD, I'm speaking. When we tried to digitalize from 2010, 2010 we actually started. So it took a period of time. That is one-time investment. Now we are almost paperless in OPMR. So for a long term, it's a one-time investment. And that doesn't directly go into the patient's bill, what you say, like IP bill. And another thing, quality. So you go to government hospital, what is the reliability? I don't know. The records reliability. Whereas here, when you digitalize, we have records. That will speak up. So that's why people prefer. It's a choice. That's it.
Understand, but for making this less, they need to put more human resource on that as well, right? For this less.
You take the you are in material management or supply chain management. In general, we talk about not reducing the cost, adding value. As many as movement of material or human being involved in your process, it will increase the cost. But this process is directly reduce your unnecessary movement, which will ultimately reduces the cost in you.
We call it non-value.
Non-value.
What do you have a point?
Sure, as he told that it will human resources will be added, but I feel it's opposite. So one computer, if I put, it can 10 people, it can be compulsory like that. So obviously human resources will be less. So in that terms, it can be manageable also. So if I'm paying for 10 people, and in the other terms, if I have one computer, that is for longer time, I don't have to pay. So cost will reduce.
Yeah.
From hospital point of view, cost is coming down. Okay.
But for patient, the cost is very high.
No. It's not. Yeah.
In between this private hospital and the corporate hospital, this public hospital and corporate hospital, we need to understand the policies. In public hospital, we are more focused on preventive care and less of curative care. And we have the resource constraint, and we want to maximize the number of patients we are being served. So in that way, length of stay matters. And we need to know the process flow. There are some OPD processes, there are some IPD processes. So in OPD process, suppose if you go to an hospital, a public hospital, and you go and see a consultant. The consultant give you a tests. So go to laboratory and get the test done. Now, if that laboratory gives a report after 24 hours, there is a problem, then you have to go back home, you have to come back, again see the consultant, take a time and see the consultant. So in that way, when we are using this queuing method, we try to bring down this turnover time of this laboratory testing and the report generated. So we try to minimize the resources used and maximize the output. This is in the public sector. In private sector, most of the IPD cases, they have their packages, and they have standardized their package and they have standardized their length of stay. So once the length of stay increases, the entire hospital cost increases. So private hospital tries to manage the entire procedure within that time period. So in that case, this predictive discharge algorithm comes, that at what time we are supposed to get discharged, but if it increases, why it is increasing, and how to reduce it. So these are the different things. It's not that our money is, means in government thing, exchequer are paying. There are some equity factors, but in private means patient have to pay, but again some part are there which are hospital is also liable. If you are there saying that within 3 days you are supposed to get discharged, so you are supposed to get discharged. If you are charged more, then you will ask that hospital why I am charged more due to problem with the hospital. Then
So one more point.
Please.
So I think from before any hospital or institute integrates a system like this, making any investment into something like this, they do a cost benefit analysis. So even though investing in a system like this might not give you a direct monetary revenue, but by addressing all these concerns that everybody here mentioned, these benefits, when you convert it into monetary terms, you are saving a lot. And by not integrating these systems, due to improper patient flow or poor bed management, there is severe monetary loss that is addressed. So by spending more in these systems, certainly a hospital is spending money. But if you look at the benefits, it's saving a lot on losses that is caused due to poor management. So I think that's why it's worth putting money into something like this.
Yeah, every point is valuable and sure. And another small question, sir. We are talking about AI and ML in healthcare sector, right? So most of the healthcare companies or hospitals, whatever, institutions, they don't know much about technology part. Again, they need to rely on some third-party agencies or companies to build this process, all these things. Again, they need to give all the data.
You know, those people sitting here, they're all doing a lot of, and you kind of insult them by saying,
No, sir.
Don't know technology. I'm thankful for your questions because those are important questions. But let us understand two different things. Number one is the willingness to improve patient flow and patient satisfaction. That's the number one thing, right? Patient should get well. Once the patient gets well, the patient should not be in the system 1 second more than what they should be in the system. You agree with me?
Yeah.
Doesn't matter whether it's private, public, anywhere. We just went this afternoon, we went to get a coffee, we ordered, we sat, coffee came, we drank, we came. That's all it.
Yeah.
If they forgot, if they did something talking to somebody, you didn't put extra people, but they didn't do their job, or they did not have the information to do their job, or information of one that gentleman was talking about was not available for the information of the other so that they can take the ripple effect. All these are issues that complicate sometimes, which could be very simple.
Okay.
So, and people are doing their job. Nobody is sitting in a healthcare, if you go, saying I'm not doing my job, because they have signed up because they want to serve people. So how do you make their lives better is the question. One of the ways of doing that is these kind of systems, because you have digitized anyway. It was not even a choice whether you have technology, you don't have technology. People have not now, because a hospital cannot even talk to somebody else without some technology available. So that's how it has become, whether it's a small clinic, big clinic, whatever it is. Level of technology might vary, but technology itself is becoming at par. So the question now is, having digitized, how do you improve your system is the question we are asking. And what we are presenting to you all is a lot of different tools. None of these tools is going to solve your problem 100% of the time without your willingness. An example is, if a doctor does not come on time, the number one reason for delayed discharges is physician not coming on time. Now tell me which technology will solve that problem.
No technology.
But information towards physicians' attitudes can solve that problem. Information that goes when physicians are trained in medical college. Medical colleges don't train physicians in supply chain management. Tell me which medical college does that. We have now in the United States forced certain colleges to introduce this at least as an elective, if not as the main course. So it's important as the world changes, technology comes to various places, hospital administrators are striving to get this technology. Unless the behavioral change of people who are working on it, in using this happens, things will not change. Change management is not just the technology. We all know that. People have to change, not technology. But technology is a big motivator for doing it today. That's all we are trying to present. We are not saying this will solve everything. But as the gentleman said, having digitized, the next step would be to see the data that's coming from your digital footprint. You have put up digital footprint now. Data will come. Whether you like it or not, you take your mobile, you take that computer, it's collecting data somewhere, it is sending something.
Yeah, true.
So it's a shame that that just stays there, nobody is using it. That's what we are saying. How do we use that? How do you make it? So the resource implications, as you rightly said, in the initial stages, more resources are needed because you are setting it up with the hope that the information that comes later on reduces the resources that are needed to manage. Right?
Yes. Thank you.
Thanks for your question. So just to conclude, we have these kind of things that came up where you had different application areas like demand forecasting, inventory optimization, logistics, surgical kits, bed management, and the kind of examples that you saw. So these are the ones where you see things are happening now, whether globally, locally, these are happening. Softwares are there. Slowly they are getting matured, more matured areas, so that we could have some trust in these kind of software. It takes time. Data has to go in. It's a new technology and technique. So I have moved from pilot projects to enterprise-wide operational systems. Many global solutions use hybrid models. So it's not just the AI alone. You have to use your own techniques that has worked in the past. Please don't abandon anything. People have worked for a long time on a lot of solutions. So augment those solutions with AI. So some frugal AI models customized with low resource contracts. If data quality can be improved, that's the main thing it is. Wrong data into these things, wrong results are going to come out, which is always the case, right? Garbage in, garbage out, they say. Wrong data in, wrong data out, wrong solution out. We've talked already about this ABDM and the kind of things that happens in the, we talked about COVID, so we've talked about the vaccine type of things. Some early warning systems for disease outbreaks, identifying high-risk populations for targeted interventions, optimizing vaccine storage and transport in rural. These are pretty solid areas because they repeat. They repeat from year to year as you look at it. So some of the issues that you see when you start looking at data is connectivity issues. Poor sensor coverage, remote areas, electricity issues, all those type of things have still to be addressed. So it's not a cure for all the solutions here. Public-private cooperation, collaboration are very critical. We cannot do this kind of thing in the large scale only with the private sector or only with the public sector. So it has to. So a lot of these corporations are trying to do that. Narayana Health, Apollo Hospitals, all those people are trying to provide their solutions that they have invested to public hospitals to use and report data on this. Talked about Niramai. I talked about this ThriveCare. We also talked about pharmaceutical supply chains, warehouse optimization, forecasting again. Now we are talking about maternal and child health programs, forecasting needs there, infectious disease control, natural disaster response. All these are areas that AI and ML can be used. So, key India takeaways. Just want to spend some time and then come back and ask you any thoughts you have. So, data availability is one of them, fragmented but improving. AI adoption maturity, emerging but uneven. Private versus public sector. Private is leading, obviously, for the cost issues, but public sector starting to scale. Thank you for the information that you gave. Regulatory push is good. Skill development need still is an area to think about, so please focus on that one. I am now going to go to the in-class interactive exercise because I just want us to, we've heard enough. So let's do this. So, you are part of the AI ML task force now, okay? You're all as a team that you're doing. Advising the health ministry of a large Indian state, could be any of the states that you want to pick. That state is launching an advanced system to predict and manage vaccine shortages across its 2,000 primary health centers, PCHs. The current stockout problem is 10 to 15% of PHCs run out of certain vaccines. Example, MMR, hepatitis B, TPT. Every month, due to demand spikes, late supplies, and spoilage, the state wants to build an AI-powered demand forecasting system. So that is your task, that the state wants to build an AI-powered demand forecasting system, okay? So, small group task. What types of data would you collect? What ML model types might work best? What challenges might you face in this context? How would you build trust and explainability into your solution? That's your task.
Yes. Done? It's over? So you are ready to have some developer hired for you? Your model is ready? You just need some developer and coder for you, isn't it? Okay. Can we start the first question?
Yes.
What types of data? Yeah, we can start from this side. Yes.
Ultimately, we feel that all data is essential to build a strong AI model. But then we felt the first two would be very essential as in transaction and demographic for the case of inventory, and the age group comes very essential in terms of vaccine administration. So to design any model, we need inventory plays a major role. Like what is there, because we are talking on the context of spoilage and late supplies and also demand spike, and also inventory plays a crucial role, I feel.
for that. Okay. So you will collect only 8,000.
No. Inventory, transactional data as well as demographic data, where we feel the other two is also important, but primarily this is the most important we felt.
Actually, data.
Sorry, what? In terms of inventory, which is stock in and stock out.
This vaccine procurement details, that stock outs details, and like how many vaccines has been used in a day. That kind of details, like, yeah, actually, ma'am.
What one?
Yeah. Sorry, ma'am.
Wow.
Yeah. Yes, ma'am. We are sharing the information, right? Yeah. Okay. In transactional data, we can see the reorder frequency also.
Which one you said?
Good afternoon, ma'am. Under transactional data, we can also see the expiry and the spoilage reports. And under transactional, ma'am, when it comes to vaccines, stock out incidents to find out which vaccines have run out.
Right. When it's an outcome, what that's that? Oh, that's a body.
In demographic, maybe we can see the migration pattern at that point of time, how many people are going to other places to visit. So that will affect our. Yes, ma'am.
What are the point in the data types of data?
Ma'am, in environmental, we can say weather data.
Data.
And any regional event or festival is going to take place, there is a chance of more contraction of that.
Whether it's like
Yes, ma'am.
so
That's the point, ma'am. Seasonal outbreak of diseases.
So at that time we might need. And then like festival during leave and holidays, people tend to bring their children to vaccinate. So that's when
Yeah, so they have mic. No, why? The rule still applies, okay?
I came late. I came late.
Accepted.
Yes, yes. Is the thing that you were saying, madam, one is we are looking at primary health centers. So at least in India, every primary health center has a birth register office. So they would have that data. But with respect to vaccine like hepatitis B, this demand is uncertain. That will depend on the regional, like if there are more intravenous drug users, they might require more of these kind of things. So that will again, where we will need to forecast or plan inventory.
Sorry, the data type. What kind of data type? Lot of data type. Add on something?
Yes, yes. Actually, sensor data in terms of the supply chain where IoT cold chain monitoring has to be done. Then GPS trackers.
Okay.
That's enough. Yes, yes, from a data standpoint, we understand that you're going back. What error on the side of both the always model capacity, some of them were not. It is always dropped. We just drop variables that we add later on, forget. Both ways models work. So think more. Environment talk about narrative, talk about weather patterns, you talk about operational, a lot of things. Yes. Anything else, the data side that is not covered.
Maybe real-time data. Real-time data they have to take operational data. Maybe maybe demand in particular such area. How many vaccines are needed for a if they demand how much demand they demanding for a particular vaccine, they have to supply should be a particular so
That we can monitor how many patients are, what is the fact,
Like, what is the trend? Sunday more, Monday less? Yes.
Did you have any additional points?
Well, shipment, like demand spikes and late supply. Very good question, and we have split the question into three parts. Means demand spike, late supply, and spoilage. On these three bullet points, we have again the data.
Okay.
So on demand spikes, we took the age-specific population growth rate of the particular catchment area of
So demand spike, you're talking about population growth rate.
age-specific population growth rate of that particular catchment area.
Okay.
The next thing is the history of any recent outbreak
Okay. People talked about that. Yes.
and the socio-economic aspect of the particular population.
Okay. Socioeconomic. What is the reasoning behind socioeconomic?
With some vulnerable population, chance of getting affected by a particular disease is more. So we have to plan accordingly.
How does that lead to more shortages?
If the number of outbreak may increase due to a particular socio-economical condition, so in that way demand will be more.
Okay.
So
Good.
next point is the late supply.
On late supply, we have this demand to supply lead time. This data we need. Another thing is the environmental constraints. There are two types of environmental constraints. One is the geographical terrain, and another is natural calamities if happens anything. So we will take this data, and then mode of feasible transportation option available there. So for late supply, we will take this data, and for spoilages, we will take vaccine wastage rate depending on the return vaccine from the camp. This data and the cold chain data and its failure, the frequency of failure, and the wastage due to this failure. This data we need. So it is it.
All data types your decision supports. We will have models certificate, right?
Sure.
Yeah, we can start with the same thing. Then model.
Sir, as per given like demand spikes and some late supplies, demand spikes, we may have like forecasting. That may help with the demand spikes, like regarding what he said, like demographic data. Forecasting may help with the demand spikes anywhere, how much data, like having that data may help with the demand spikes. And for late supplies, we can think of like classification, like these supplies and these are things which can be made into this particular department, or like this particular areas we can send these vaccines more, and this particular area we can send less vaccines. Classification of that area, and a reinforcement learning. After sending that also, after 2-3 months or 4 months, we'll get a data what is happening with that, what we have sent with the batches, and we can reinforce learning and encourage our model to learn more data, have more data. And then spoilage, as a spoilage we can know that forecasting and using clustering we can predict some different thing, like we can have no like we can have different approaches by clustering.
See, it's not that we have to use all the tools.
No.
Okay, you have to be very clear. This will solve this problem, this model. Okay, or you have to be very clear. This problem one technology tool, this problem one technology tool. You don't need to fit all the things.
Like one thing demands or late update and
No. I just want to make an observation kind of supporting that. That's why I put this in. The state wants to build an AI-powered demand forecasting system. So let us help the state build a demand forecasting system and the tools that you need to build a demand forecasting system. Okay? So just wanted to make sure we remind ourselves what's our task on hand, what does the state want, not what the analyst wants. Analysts are always people with more enthusiasm. Whatever they see is a nail, so I'm going to put the hammer on it. So that's a good one, but that's not a nail. Okay, okay. But thank you. Looking at other models and where they can be applied.
It is more focused. Yeah.
We can go with the classification model of AI on which age group needs which kind of vaccines using classification models. Yeah, which PHC also we can be, which area in the state needs this kind of vaccine, we can use classification. The forecasting will be, we can use time series.
It does how it can classification.
Yes. Yes. Okay. We can in turn we can forecast. We can use the focus model also. Like we can make a hybrid model. Yeah. Classification will give you the demographic. We can classify the demographic according to the age. Yes. Yeah, we can stock accordingly. Yes.
Back. There is no right or wrong answer. This is your thought process. So,
Clustering model is an important component, I feel. So where we can segment the PHCs and we can see what demands they are facing and any logistical challenges are being
okay. So clustering is the winner. Let's keep going. Remember what we are trying to forecast. Certain types of vaccines that are used towards MMR, hepatitis B, and DPT.
we can go with this forecasting, machine learning and classification and clustering. So forecasting is an first ultimate important machine learning for predicting the demand in future and also referring the historical data also. Then clustering in the sense we can cluster like states and cities with a similar usage and demand behavior, and in classification like high risk at shortage and low risk at shortage, that kind of thing. So this models is an important thing to adapt in these situations.
So for forecasting, you're using machine learning.
Yes, sir.
Okay. Just wanted to make sure.
Yeah.
Okay. Good. Next. Yeah, they have mic. Why are you not talking? The back. I wanted the back. The nursing staff should be chilling.
Sir, actually, I would go with the clustering, so that we can cluster the groups which are more vulnerable, so that we can supply more there.
Wonders. Back.
So we would like to use forecasting and classification model.
Forecasting is not a model. What would you use to do the forecasting?
Forecasting in the sense like a number of deliveries of babies. Based on that, hepatitis B is one of the most demanded vaccines, which has to be given at birth. So based on that,
that's why I wanted to ask you that question. Okay. Okay. Let's see these things are not equally likely at the same time. They are different periods. Okay. So you have not answered my question. The question was, what would you do for forecastings? So from an AI perspective, what is the tool? I think that team talked about machine learning. So that would be a good tool to think about. Multiple variables come in for each of these products, vaccines. How do you forecast demand? And then you are nuancing the demand to other things. So I'll wait. I won't say anything till the other teams. Okay, pass on. No, back. Men are always going to take the mic first.
Decent data.
All right, we have the guest speaker. We should not make them wait. So go fast, please.
So actually, add on some points on that we'll also do forecasting machine learning. So based on the data, some season the patient will be more like during summer season, during winter season, patient will be more and they demand for the vaccine. So based on that, we'll do forecasting. During this season, many patients will come and they will demand for these vaccines. So that we plan and prepare for those situations.
Okay. Team, can I ask you to weigh in on the next question? What challenges might you face in the Indian context? I want the discussions. We got two more questions we want to address. So what challenges might you face as you are developing this AI-based tool to help the government to forecast? What would you face?
We may not have existing data in place based on which we need to build up these models, and adoption may be an issue because a lot of these people working in PHCs may not be IT conversant.
So data is an issue. Let me go there. Did you think of anything else, please? Okay. So again, related to the data availability, yes.
so in the point data quality, I think incomplete or delayed entries, it may affect
it may cause challenges. Also, language barriers will be there.
Language barriers people are talking about. So again, collecting the data, accuracy of the data.
There are also poor internet in the rural or remote PHCs.
Okay.
And,
So infrastructural kind of challenges
Yes.
in that sense.
and in the adoption barriers, there are resistance from ground level staffs, and a lack of training will also be there.
Okay. One of the things I wanted to ask before we go to the last one in this, what are some of the biases that you talked about? Think about biases. What kind of biases do you think would be there? Model bias.
Yes, model bias.
Yes.
So like it's data is not equally distributed in urban and rural area, and it's like inconsistent also. It's not very consistent few places.
So that kind of a bias. One type of data might skew the other type of data.
Exactly.
Okay. Anything else on biases? Anybody?
If they trained only the selected.
What is preferential bias, please? What are you thinking in that?
Very common. Sure, preferential as in it should be common for accessibility, like availability or accessibility I'm telling about.
Sure.
So
What is the preference that will come into a data as you're
maybe the economic status of the person. So there comes the preferential biases.
Maybe we'll go with that rural-urban kind of a divide where the economic status also might play a role. Okay, let me finish with the last one. How would you build trust and explainability into your solutions? If you are now tasked, you cross all these hurdles and you somehow build it up. What would you do? Now you got to sell it so the people can use it. So the question comes, how would you build trust and explainability into the solution? With whom? Okay. Awareness campaigns, okay. Okay. Okay, who had problems here? Does public have problem? I just want to make sure whose problem we are solving. State's problem. What was the problem? One more time. Shortage of vaccines. You're building a model to do what? Predict the demand. So to whom are you selling this? To the hospitals or to the state people who are now going to depend on you to say, I'm going to order more, or other kind of things that you're going to talk. So now tell me, what do you do to increase the trust? Because these are people who are, first of all, as you said, some of them are not tech savvies. Some of them are not going to trust the solution that a computer is going to spit out. Leave alone, you're going to use the word AI to do that. So communication again, but to the wrong type of people we are talking about. To the right type of people you have to go. Good point. Good point. Anybody else? Okay. Good. Good.
So how many entrepreneurs we will get from here? Make such systems, for the sake